thinking. He's been asking me several times.
Yeah.
Okay. Okay, good afternoon. Is it too loud? Okay. So, after lunch, is usually I have to stay awake, and the only way I can stay awake is that you guys ask the questions. So make sure you ask the questions. Challenge me. Make it more interesting. So we'll talk about, I'm going to kind of try to skip things now because otherwise you'll be here till 7 o'clock in the night. So instead of 7 o'clock, I'll make it 6:30. Alright, conduction blocks. Just what is a conduction block? Remember what I said? Blocking the pathway. Oh, slow. So just think like that. Conduction block, something is blocking. So so in any obstruction or a delay of the flow of electrical impulses along the normal electrical path. So සමහරවිට ගහක් වෙట్లా ඉන්නත් පුළුවන් එහෙම නැත්නම් පාරේ අපි කියමු ඉඳලා හිටලා කරන ලේන් එකක් වහලා ඉතලා එතකොට ඉතින් පොලිසියෙන් කන්ට්‍රෝල් කරලා එක එක ටික ටික එතකොට ස්ලෝ වෙනවා. දැන් ඒ වගේ තමයි ඉතින් එක්ක ඩිලේ එකක් එක්ක block එකක්. It can happen anywhere on the conduction pathway. So what is the conduction pathway? Anywhere starting from the sinus node, going to the atria, AV node, bundle of his, right bundle branch, left bundle branch, anywhere on those. So we talked about sinus node block earlier. So Tariq, there is something like that. It's okay now? Okay. We talked about the atrioventricular node. Sometimes the block can be right there. Bundle branch block. It could be the right bundle branch or the left bundle branch. Sometimes both. So here's the way we look at the picture. And here's the sinus node. Sometimes the sinus arrest or sinus exit block. Sometimes there's an AV block right here. AV block can be anywhere from this here to here also. Bundle branch block, it could be the left bundle branch block or the right bundle branch block. Sometimes you see it could be even just one fascicle of the left bundle branch. Remember, I said there are 3 fascicles, anterior, posterior and septal. Sometimes it could be even one of those. So 3 types of AV blocks. So we are going back, now we are talking about, we already talked about sinus arrest and sinus exit block earlier. So let's talk about the AV blocks, okay, atrioventricular block. Now it can be first degree block. We talked about that too. What happens in first degree block? There's a delay. PR interval ST segment is bigger. So there is a slowing down until somewhere here. Now second degree blocks, there's one called Mobitz type 1 or another one called Mobitz type 2. Then we talk about third degree blocks. These are important. So even though you may not remember, but once you hear these now, maybe one day you'll be able to remember, oh, that's what Dr. Ranasinghe was talking about. Okay, so we talked about these AV blocks. And so first degree block, it can be prolonged, it's a prolonged PR interval, more than 0.2 seconds. So we had this EKG earlier. If you look at here's a P wave, here's a QRS interval. See how long this is? P wave, QRS interval, P wave, QRS interval, but it's long. So this is the first degree block. Most of the time it's not a big problem, but sometimes it can be, okay? Mobitz type 1, the second degree blocks. This was the first degree block. Second degree block, 2 types, one called Mobitz type 1, it is also called Myocardial block. This block is inside the AV node. And it is unusual, I'll show you what. It has this interesting thing that PR interval, that line gets longer, next one is longer, next one is made longer, and then it drops a bit. and then whole thing starts all over again. And usually this is not that dangerous also. Type 2 is dangerous. It can be, sometimes you have P wave, QRS, they're completely dropped. Because the reason, because this is called a high degree AV block, because this can change to a third degree block. I will talk about third degree. So this one and the third degree blocks need pacemakers. And we usually put the pacemaker right away until they get the pacemaker inside. So I just, like I said, I know this is really complicated, but just remember to that they are possible, first degree, second degree. So one of them first degree Lanka, you see Warpage type 1. Here's the PR interval. Here's the PR interval a little bit longer, and now it has dropped. PR interval. So then it starts cycle all over again. So that's where the block is. So it's not bad. Type 2, look at what happens. Here's a P, here's a P, and here's a P. That's no QRS. Here's a P, QRS. Here's a P, QRS. Here's a P, but no QRS. And same thing, it can happen again. See? So this is a 2 to 1 block. This is 1, 2, and then block. That can continue like that. But the danger is that this usually, if you don't treat, will go to a third degree block. When the block, is 2 block again. PR interval increases, drop B. Start again. 2 to 1, no QRS. 1, 2, period, no QRS. Third degree block, now what happens is atria and the ventricles are totally not talking to each other. Like you had a fight with your boyfriend. You don't want to do your thing, or your girlfriend. You do what he wants and you do what you want. It's pretty much like that. They are not talking to each other. So atria are now having their own rhythm, regular their rate. Ventricles are having their own thing, beating on their own at their own rate, and they are not even coordinated at all. So here's what happens. Okay. So the block, these are high degrees. They are dangerous. They can easily stop the heart and die unless you do something about it. So those can be anywhere on these sides in the pathway, conduction pathway. Anyway. But higher the block is, the worse the problem is. So what happens? Here's a P wave. Here's a P wave almost mixed with the QRS. Because the beats are ventricle beats are coming from the ventricles. See how wide it is? So it's a wide QRS. When you see wide QRS, you know that it's coming from the ventricle. But the P waves are, if you measure the P waves, they are regular. But if you measure the Q waves, they'll be regular. But it's a slower rate because remember, ventricles less efficient. But they have nothing to do with each other. P and QRS are independent. This is very, very dangerous. When we see that, we put the pacemaker right away. So, then with PVC, you don't need to do that. Okay, so what is this here? Anyone? There's a P wave, QR is not wide, so it's not really ventricular. This is actually, first degree. See, PR interval is long, but no drop beats. I don't see a drop beat. But what is this one here? Here's a PR is longer than this one. PR is now much longer, and here's a drop after this one. This is Lanka, Warpage 1. So it gets PR interval get longer and longer, and then finally after P no QRS. And this whole thing starts all over again, another cycle. And what's this one? Normal PQRS, P but none. Normal PQRS, normal QRS, P, none. There's no left getting bigger. PR is the same. This is Warpage 2, type 2. And type 2 again is bad. And then of course here's third degree P, and if you get a little measurement, P's will be regular, QRS will be, they are all regular, rates are independent. So bundle branch blocks ECG when one right bundle or the left bundle gets blocked. And right bundle blocks are not that dangerous, but sometimes they can be important. So essentially what happens is, and I'm not going to talk about all these details now for you, but here's what happens. So the interconduction, we will again review. Here's the bundle of his right bundle branch, left bundle branch. So blocks can in the bundle branches can be here or here only, not up here. So when you have a bundle branch block, you see it could be like left bundle or it could be right bundle. So here's a right bundle, you can block here, that will affect the right. So which are the right bundle? Right bundle supplies which part of the heart? Right ventricle, which is what leads are the important things which show the right V1 and V2 primarily. So if you want to look at bundle branch block for the right bundle branch block, look at V1 and V2. Left bundle supplies the left heart, and what are the leads for that one? V4, V5, V6 primary. Yeah. So let's look at it then. Now, so what happens V1, V2? Because bundle branch slows things up. You see, bundle branch can be either a block or a delay. See what happens with the QRS? It has this. So this has, tell me, there's no Q wave here, right? There's an R wave, and there's another R wave here. So what's the second R wave called? R1. So in the bundle branch on V, we look at it V1 and V2. They will have this R1, R and R1, which we call repeaters. How Aztec way? So if you see repeater like pattern, white QRS in V1 and V2, you can say that patient has right bundle branch block. So it is not as bad as left bundle branch block. Left bundle branch, you want to look at primarily what? V5 and V6 and see how they can get white here. See that? So these are primarily bundle branch block. So again, I don't have a problem if you cannot remember this stuff, but at least you know what left right bundle and left bundle branches are now. But the left bundle branch, if you remember, it's helpful because left bundle branch block is supplied by the left bundle going to the left ventricle. So that means the block could be due to not enough blood supply or a block to the blood circulation to that particular side, which is like it's a heart attack in a way. So when somebody comes and we look at it as a left bundle branch block, ECG, that's an emergency. If the patient had a normal ECG, say 1 week back, 6 months back, because it's a new left bundle branch block, it's a new thing for this patient, that is not good. So you have to remember that new left bundle branch is really important. Sometimes patients get bundle branches if the rate is too fast, just because it's growing. So I'm not going to talk about it here. In bundle branch blocks, you can get this like hypertrophy, some changes like that. All right. So similar to hypertrophy, like sometimes. But the difference is that it's a bundle branch now. So I'm not going to. We don't need this now. Pacemakers. So who needs a pacemaker? Patients who have third-degree blocks must have a pacemaker. Patients who have morbids do, because they almost always go downhill and get third-degree blocks, and third-degree blocks go into ventricular fibrillation. So, and if they have a very slow heart rate with a sick sinus syndrome, sometimes they have normal periods, and then patients come say, oh, I was walking and then I fainted. See, that's why when patients come here and say, I fainted, we do the ECGs and all that stuff, we admit them sometimes, because maybe their heart rate sometimes drops too low. Sick sinus, sinus node is sick. So sometimes they have so left bundle branch. These patients need pacemakers. So where are the pacemakers placed? Sometimes you have the atrial pacemaker only, which pacemaker there. Sometimes they can be only in the ventricle, it goes to the right ventricle usually. Sometimes they have a dual pacemakers, or what's called sequential pacemakers, one in the atria, one in ventricle. So these will help to save patients' lives. See. So remember, pacemakers are one of these, but these are more commonly used now. And so when you see a pacemaker, they have this pacemaker beads separated. See that? These are pacemaker beads. These are not normal QRS complexes. This generates the heart to contract. So these pacemaker beads show up like this because straight line, small, short ones. Here's a patient from a ventricular pacemaker. But again, I'm just introducing this to you. You don't have to remember. Here's a sequential pacemaker. But idea is that if you see this little straight line before the QRS complexes, just think that patient had a pacemaker. Okay, you don't have to remember why. I mean, if you know it, especially it's okay. Sometimes the pacemakers are placed outside the heart also, or the cardiac pacemaker. Okay. Yes. So this any questions on Barnum branch? So only thing I would like you to remember is that conduction blocks are some delay or blocked on the pathway, and then right bundle branch block at V1 and V2, and it's traffic years, because remember bundle branch will delay the conduction, therefore QRS will be wider, and then of course left bundle branch will get V5, V6 primarily, and you see the very wide QRS. Okay, well, next one.
Why would you have a sequential pacemaker?
If they have problems with both the atrial and sinus node and ventricular conduction problems, then they would prefer to have a sequential pacemaker, because you see that way they can guarantee that both atria and ventricles are coordinated better. Yeah. But some people, it performs better. So essentially, it's stimulating both the atria and the ventricles. Okay, so next one, pretty exciting. You know what, I'm going to roughly introduce this to you because it's a little bit complicated. So there's two important things called Wolff-Parkinson syndrome and Lown-Ganong-Levine syndrome. And Wolff-Parkinson's why is important because this, has anybody seen WPW, Wolff-Parkinson white ECGs? So it is using a bypass, you see, bypass. And it's normally the PR interval is like this, and then in this case, this part gets shorter. So if you really look at it, what happens is, see, here's a normal P and then the normal pause. But here what happens here, here's a P wave, there's no line at all. It just, see how that, can you see that? You see here P pause, but there's no pause here. It just merges into the QRS complex. But because it's a P, this is narrow complex. Because you see they have this bypass circuit or a racetrack normal conduction is this way, but they have this abnormal tract. So anyway, so that triggers WPW syndrome. So if you see the PR interval really narrow and the P kind of merges, connects with the QRS, think of WPW. The important thing is this, they can have bad atrial fibrillation. So when they have atrial fibrillation or some other tachycardia, you cannot really see that. So here's a WPW, we see that. P wave and no PR interval straight line, they can connect a QRS sector. P wave. So that's how you know there's no PR. That's why it is important to look at the ECG step by step. P wave, the straight line, QRS like that. And then you can identify abnormalities. So that can trigger in the PSVT, not supraventricular tachycardia, or atrial fibrillation. See how irregular this is? So those have to be treated in a different way. And here's another PSVT, atrial fibrillation. So okay, summary, WPW, short PR interval is much shorter than 0.12. The delta wave, or conductive equivalent delta wave, you don't have to remember that. QR complex is a little bit wide because it's merging. That's all I want you to remember. And after treatment. Okay. So I think we are coming to most important things now. These things I told you now, even if you don't remember, but at least remember WPW is a short PR interval. QRS and that can be a risk problem because they can get rapid heart rate and rapid atrial fibrillation. Other than that, it's okay. Okay, here comes to the interesting part here. Myocardial ischemia and infarction. So, acute coronary syndrome, have you heard the word acute coronary syndrome? Meaning, you see anything from a ischemia, angina to a heart attack. So, what is myocardial ischemia? Yes? What is that? Poor blood supply. Lower, not enough blood supply. Yes, that's true. Poor blood supply. But blood supply is not completely blocked. So people with ischemia, when you walk or do any climb stairs, your heart has to have more blood, but it's not getting enough blood because your coronary arteries have narrowed. So there's not enough poor blood supply beyond that narrowing. What is infarction? Infarction is complete block. That means there's no blood beyond that point. Block, completely blocked. That is a heart attack. This is not a heart attack. This is what we call angina usually. So how do you diagnose a heart attack? Most important is what the patient tells you. You have to ask the right question. Sometimes patients don't know how to explain that. You have to ask, did you have a chest pain? Some people say no. All those stuff. Because you have to ask the question. Because even in the US, people sometimes don't know how to express that. So you have to keep probing. Nikang maybe. Usko kanda wage na It's common way. So probe and probe and probe. And so those are the questions. You see, chest pain can be tightness, heaviness, pressure. Does it go anywhere else? Down the arm, to the neck? The usual questions you have learned for heart attack. Difficult breathing, nausea, sweating in women. Sometimes they're difficult. Diabetic patients, difficult. Sometimes they don't get. I had a patient, in fact, who came at 4 in the morning. And he said, I have a sore throat. So I went there. He's like about 58 years old, I think. I went there and I looked at his throat. His throat is a little red. So I said, well, you have some pharyngitis, So I came back to my desk. Something told me you better go and ask him. Then I went back. I said, how long have you had the sore throat? He said, it woke me up with the sore throat. I said, you got it suddenly or slowly? Suddenly. Do people get sore throat suddenly? No. I told the nurse, get an EKG. He had a heart attack. So that's why you have to look at the picture. Age, 58. So high risk age. I think he may have had high blood pressure or something, I cannot remember. But the most important clue he gave me was sudden onset of a sore. Otherwise people usually have a little cold symptom. He did not know how to express the pain. That was a pain he had in the neck. But he said that he thought it was a sore throat. If I had let him go, he would have been dead. So remember, it's important. So where do the coronary arteries happen? Blockages happen. For example, now here you have the right coronary artery. Then you have the left main right here, right there. Then it divides into left circumflex and left anterior descending. That's from your anatomy, right? So angina is like this when there's narrowing due to the atherosclerosis plaque. So if the heart needs to work harder when you exercise, get excited, climb stairs, but not much blood, not extra blood can go that way. And block is easy. Now the plaque forms a platelet aggregate blocking the part. Beyond that, no blood supply. That part, unless you go and clear that block, this part will die. Once the heart muscle dies, it's permanent. So you have to take action during that time. So when the heart attack happens, next thing is that we do blood tests. ECG can be normal initially. The blood test can be normal initially. But things especially look for is, of course, myoglobin and troponin SCK. But troponin is the most important thing now, and initially it can be normal. But after 4 hours, especially after 6 hours, if they're having a heart attack, troponin goes up. So when patients come, I ask all the questions, then I ask, what time did you feel? I started at about 1 o'clock this afternoon. So I tell them, you see, I'm going to do an ECG and a blood test. If they are normal, I have to keep you for 6 hours. And then if they are normal, I keep them, and at about, usually after 4 hours, close to 6 hours, I do the second blood test, second ECG. Second ECG can be normal, second blood test. Many times I've had come completely abnormal, high. So normal ECG, enzyme tests, those are called non-STEMI. You've heard of that? Meaning, you see, non-STEMI is ST, non-STEMI is ST elevation MI. Non-STEMI means no ST elevation in the ECG. So that's why you have to be careful. So what happens in the ECG if there are ECG changes in a heart attack? MI means myocardial infarction. If it happens in the book, according to the book, first thing happens is see what happens to the T wave, repolarization, electricity is much higher. So the T wave becomes peak. So if you see peak T waves, either it's a heart attack or anybody? They've seen this before? It can be hyperkalemia, hypotassium. So if you see this one, either the patient is having a heart attack or it could be due to hyperkalemia, sometimes more. And then next step is now the T becomes inverted or called T inversion. And next third step is the STs go up now. See, ST segment is this one right here, remember? And now the ST goes up. And then later it comes down. Now this is the typical way it will happen according to the book. But you may have a patient who comes right here or here. You see, so that's why we have to put the whole picture together. The history of the patient, your exam, and then your ECG and blood test. So here's another T-wave peak right there. And then after 2 hours, if you do another ECG, we usually repeat the ECGs every half an hour. Sometimes I do every 10 minutes. And see now the T-wave has inverted. So if you see this kind of a change, you know that this patient most likely is having either heart attack or it could be ischemia, angina. But then actual injury pattern, we call it, is the ST elevation. So when you see that one, that is heart attack. Because you see that there are other reasons STs elevate, but the way you know if it's a heart attack is see how it kind of merges with the T wave. See how it merges with the T wave. That's heart attack. So if the ST elevation kind of connects to the T wave, that is a heart attack, pretty much. Okay. So you probably should remember that when you look at an ECG. If you see that. Now, some people have normal ST elevation, but see the difference. See, ST is a little higher than the baseline, but it is not really connected to the T wave. See that? You still have the ST straight line. And this is called J-point elevation, and some young people have this as normal. But I want you to look at this again. See the difference, how the STs are higher and it connects to the T wave. This is different. It has still the straight, even though it is high, ST is higher than the baseline. Here's the baseline. ST is still higher, but T wave is separated. If you are not sure at your level, just tell the doctor, I'm not sure whether this patient is having a heart attack. You see the ST is elevated, then they can figure it out. But remember ST elevation. But if you know the difference, still you should tell the doctor to look at it anyway. Obviously, do, and see how how the ST elevation and the T wave connected. See that? So, all right. So, why do the patients form Q waves? Well, Q wave is actually once the heart attack has completed. Oh, wait a minute, I forgot to mention that to you. Yeah. See that right here? Once, here's the ST elevation, and what's this wave? What is it called? What is it? Q wave, because it's the first wave which goes down. And see how big that Q wave is compared to that septal one I told you about, which is tiny Q wave. Anytime if this Q wave is at least 1/3 or more of the size of the R wave, that's how we determine whether it's important or not. If it is less than 1/3, we consider it as septal, not necessary. But this is definitely longer than the R part, isn't it? So that that means heart attack has completed now. Now there's permanent damage to the heart. Q wave. Q wave can permanent damage to the heart. That's happened. So here's a patient normal patient, slight elasticity, and this is after the heart attack. You see how the Q wave now? No Q wave. Same patient, no Q wave, but there's a Q wave. So why do Q waves form? So let's say that patient had a heart attack, and this part of the heart muscle is dead. So when it is dead, what happened to the electrical forces? There's no electrical force. There's no cells to transmit the electrical activity because those cells are dead. So what happens to the electrical current? Starts flowing away from it as much as possible. So anytime the current moves away from your source, that's when it goes negative. Remember? So this part is dead, no electrical current, therefore electrical now going this way. Normally electrical current should be like this, but now because it's dead, electrical forces say I have nothing to take electricity there, so it moves away. So because it's moving away, that becomes a negative force. We also have sometimes in addition to the ST elevation in the actual area affected, the opposite part of the heart can have depressions like this. So these are called reciprocal changes. Reciprocal changes. Suppose if you have anterior infarction, no, this is a inferior infarction V2, and the opposite is V3 in the anterior leads the opposite direction. So if you may see ST elevation on one side, on the opposite side of the heart you may see ST depression. If you see that, that's definitely a heart attack, reciprocal changes. So here's that septal Q wave which is not significant. Remember I talked to you about? Okay, so, and this is a significant Q wave. Remember, at least 1/3 the R wave of that QRS. See how deep it is? And if you measure this from here to here, will be at least more than 30% of that one. So, again, these are significant Q waves. I'll pass that. Oh, okay. How to localize heart attack? So you can look at the ECG and say, oh, this patient is having a heart attack. That's number one. Number two, where is the heart attack? So we'll look at the blood supply again. Right coronary artery, it also supplies to the AV node, by the way. Left coronary artery comes right here, but it divides immediately to left circumflex, which goes around the heart to the lateral side and to the back. And the anterior descending is the one which comes to the septum and to the left ventricle. So that is why this is very important vessel. If it blocks it, it causes bundle branch. Remember I said it also supplies the left bundle branch part. So bottom of part of the heart leads are what? Leads. Remember, now we go back. 2, 3 and AVF. So 2, 3 and AVF, these are the leads. Lateral parts is in lead 1 and lead AVF primarily, but also 5 and 6. Right side of the heart is AVR. Okay? Yeah. So, if you look at, so right ventricle is anterior and V1, septum V1 2, left ventricle is 4 to 6, and same thing, we went through this before. Lateral leads 1 and AVL and V5 and V6. Inferior leads 2, 3 and AVL. Posterior leads, if you put them, we don't normally put them, is 7 and 8. So, so if you want to look at the right ventricle, AVR and V1, look at that. So, you can get an idea looking at the ECG, which leads causing which problem. So, 4 basic signs of myocardial infarction. Here's the anterior infarction right here. Here's the inferior infarction in the bottom. Lateral wall infarction is right there, and the posterior infarction is in the back. You see that clearly? Anterior infarction, lateral infarction, and the inferior infarction right there. So acute lateral wall infarction, which leads you want to look at mostly? Wait. Let's not just do that. Let's start with lead 1. What do you think? Is there ST elevation here? Right. You come to lead 2. Is there any ST elevation here? No. Is there any ST elevation here? No. AVR? No. AVL? Yes. So 1 and AVL infarct, the ST elevation. So it is a lateral infarction, 1 and AVL. And then look at V3 has any PT waves here too. And 5 and 6 have some Q waves. So that means here already damage has happened. Now, in the anterior infarction, is what leads? V1, 2, 3. But not always. But V1 here you can see it's a little elevation here already. And do you see ST elevation merging with the T? You see ST elevation, see how it goes up. But 4, 5 and 6 not too bad. In fact 5 and 6 nothing. So this is an anterior infarction, isn't it? Because it leads V1, 2, then 3. So it doesn't have to be all 3, but it could be 2 out of the 3. No. Posterior infarction. Remember, we normally don't put leads in the back, right? Because we only go up to V6 here. V6 ends in the mid-axillary line, in the intercostal space. But if you see a ST depression and de-inversion in lead V1 and V2 and V3, you need to start thinking, why is this? It could be ischemia, but also this is opposite to the V1 and V2, V3 are anterior leads. So it is directly opposite from the back, neither. So because of that, you see the opposite effect of ST elevation. Opposite effect of ST elevation is ST depression. So it's almost like reciprocal change. So when you see that, if you actually turn it around and look, light you see ST elevation backwards. But when we see this, I tell the ECG, I tell the nurses, call back the ECG technician. I want him to go her to do another ECG with 7 and 8 in the back. So here's an evolving anterior infarction. Where do you want to look primarily? But anyway, my point is, if you look 1, 2, 3, anterior leads, what is happening here? V1, V2, V3, ST elevations, right? And then you will see some reciprocal change sometimes in the inferior lead, but this patient does not have that. Here's acute posterior infarction again. So 1, 2, 3 are all fine. V1, what do you see? ST depression, 2 ST depression, 3 ST depression, and if you see that, so think of posterior infarction. See, doctors may say, I see, oh, you know what, no, it's maybe this ischemia, it's maybe missing nothing. But doctor, what do you think about posterior infarction? How about doing another ECG with 7 and 8 in the posterior? And that is, people can miss this because of this. So there is something called transmural and subendocardial. Subendocardial can be non-STEMI primarily. One can be non-STEMI is when the enzymes go up but the ECG is normal. Patients have symptoms usually, they just wait or try any of those. And that's why you have to keep them and repeat this test. And they are dangerous because these patients have a higher mortality in the long run than the other patients because these are diagnosed. These can be missed. So that's called, they are also called non-cubital infarctions because they don't have any cubates. But you see the T inversions, these are obstacles. And usually with a heart attack or angina, you see the T inversion is very symmetrical, perfect V-shape. That's one of the things you can look for. And the T wave inversion again here. Angina causes the same symptoms. You see with the ST depression. ST depression can be due to not enough poor blood supply. And these will come back to normal. Sometimes you give them oxygen and things like that. So, but these patients have to be admitted because that means they have a heart problem. Prince metal angina, have you heard of that? That's not a block. There's no atherosclerosis. It just spasm. Spasm and temporarily causes the block. So STs go up because heart is now clamped up and not enough blood supply going. And those who do cocaine, this can happen. I've seen that. You heard of cocaine, right? Drugs or methamphetamine or any stimulants like that. They're susceptible. Sometimes some women get it too more commonly. But they go back to normal, if you do an angiogram, it's normal. So the treadmill test is a good test to detect heart problems. Sometimes you get false positives and false negatives, but generally it's a good test. You know what treadmill test is, right? Okay, everybody knows? Anybody wants me to explain that? Raise your hand if you need. No? Okay. So that's what you look for in this treadmill test. When you exercise, if the patient has a heart problem, not enough blood supply, go like we said, poor blood supply, and then you get ST depression during the exercise. And when you stop, EKGs come back to normal when they rest. So same thing here, see normal ECG during exercise. Go up doing on the machine. Okay, let's just keep all this stuff. Just to review. What's this here? PVCs, yes. How many? Good or bad? Bad. Three in a row is bad. Alright, I'm not going to go through it, we don't have time now. Oops. Yeah, let's skip all that. One more. I'm brushing it a little bit, but stop me if you have any questions, because I know everybody's tired now. So what are the non-cardial, not really heart problems which affects the ECG, but outside factors? So let's quickly go through. Electrolyte disturbances, potassium, high or low, magnesium, calcium, low temperature, hypothermia. Is that a problem in Sri Lanka? The US? I've seen patients with that. Drugs, meaning both medical and non-medical, meaning both medications and illicit drug use like heroin, cocaine, stuff like that. Myocarditis meaning inflammation of the heart muscle like virus, sometimes viral infections cause myocarditis. Pericarditis is also when the pericardium, the sac outside the heart gets inflamed and pericardial fluid accumulates in the fluid sac. Then with certain lung problems like pulmonary embolus, clot in the lung, you can see ECG. I had a patient, it was really interesting. My son is also an emergency physician. He and I walked into this ER in San Bernardino, Big Bear. Big Bear, we were there. And when we were walking into the ER, we all meet with the physician, doctor on duty there. This was, no, I'm talking about now PE. So they were in the middle of a cold, and I could see the chest compressions going, and he said, I tried this, I said, I tried that, and nothing's working. She would come back, then she would again go ventricular fibrillation, then she would have atrial fibrillation, and she had come saying that she was short of breath. Obese woman, fat, heavy woman. So, and he asked me if I can help. So, I don't have privileges at that hospital, so I can't touch the patient, you see. So I said, okay, what have we done so far? And he was a younger guy. So I said, let me look at the ECG, let me look at the chest x-ray. When I look at the chest x-ray, I noticed that, she had elevated diaphragm. And I said, what did she come with? Shortness of breath. I said, they have done everything. I said, thrombolysis. He's asking me why. I said, I think she has a PE. And so he said, nothing to lose. He gave thrombolytics. She had a blood pressure. So transferred by helicopter. But you see, looking at the ECG, sometimes there are suspicions to indicate a PE. And of course, there are other things which can cause. I had a patient, in fact, by Lugara syndrome in Guam when I was there. This is dangerous in young people, actually. So, some of the things, I don't expect you to remember, but just get an idea. So, hyperkalemia, hypotassium, patients who are kidney failure patients on dialysis. I'll come to that. Okay. Good question. Alright, so hyperkalemia, what is the important finding is peak T wave. See that? So when you see this, like I said, peak T wave could be heart attack, and but also think about potassium. So if the patient has kidney failure, then you think about potassium, hypotassium may be a problem. The danger of this is, the next step is that it's going to affect the heart, and then heart will go into ventricular fibrillation. And so hypokalemia, and there's an extra T wave called U wave. So these are the things I'm not expecting you to remember, but just get exposed to this now. Hyperkalemia, peak T waves. Hypokalemia, the T wave, along with the T wave, there's another wave, forms called U wave. And we say, what did we see? See, this patient has 2 T waves? No, one is a U wave. So think about hypokalemia.
Is this what you see when they have people sentenced to death and they get intravenous medications for death penalty?
Yeah, the death penalty in some states in the US, they inject the patient with potassium. Or there have been, this is not funny, but it's kind of, there was a nurse called death nurse. And this nurse had this thing to kill patients. And it's a male nurse, he was injecting potassium into the IV. And they go into a rhythm problem, they go into a rhythm problem and they die. So it took a while for the hospital to figure out finally why the patients were dying on his shift. Then they figure out that he was injecting potassium, and it's potassium, you give too much, you die. Because this next thing what happens is this, with this one, these will merge, QRS, and form what is called a sine wave. Then sine wave goes into ventricular fibrillation. So you have to treat this immediately, emergency treatment. What do you normally treat hyperkalemia with? There's all things. You can give bicarbonate, and you can use insulin and glucose together, because insulin drives the potassium back into the cells, because potassium is an intracellular cell. Now what has happened is potassium has gone out of the cells into the bloodstream. So we want to push that potassium back into the cells. And the other things we give K-Xylate. Yes. So it's a thing you can give by mouth or by enema. And then of course calcium chloride if there's heart effect. So calcium chloride is the last one. And you have to save them because it can be saved, they can be saved. So hypokalemia is the opposite. Now sometimes patients come, we have this disease called hypokalemic periodic paralysis. Also, there's something called hyperkalemic periodic paralysis. The hypokalemic periodic paralysis may be more common among Oriental people, Chinese, Vietnamese people. And I had two brothers who came, they could walk. They were only like 20 years old, 20, 21, 22 like that. Both of them, hereditary. Potassium was 2.
Usually after a heavy meal.
I can't remember that, but anyway, 2. Potassium was 2. So you gave a potassium, got up and walked home. You know? So you have to, you do ECG, this is what you see in ECG, low potassium. Okay. Hypocalcemia, one of the things, hypocalcemia is increased QT length. Remember QT, the interval, QT interval right here. See how long it is? QT. Q starts here, T ends here. This is really long. And that can go into what? What is this? Here's long PVCs and small PVCs, long TOSA. There you go. So this is TOSA. Long QT syndrome can lead to TOSA. And long QT syndrome, I told you, can be sometimes they have it congenital, and sometimes due to certain medications, like I told you earlier. And then, of course, hypocalcemia can cause it too. And hypomagnesia is very common. Hypothermia, like I said, you don't see it, but we see it. It causes many different arrhythmias. It can cause slow heart rate. It can cause atrial fibrillation. But one of the things is what we call, Osborne waves. So you don't even remember that. Hypothermia, when the patient goes into, in cold weather, this is what happens. They get this irregular. It can be mainly because of the shaking, the shivering. Drugs, digitalis, see how the ST is depressed, but it has a gradual slope and then sudden quick rise. In heart attacks, it is very symmetrical, good V shape. But this is, see how the slant is slow. And toxic effects, digitalis, this can cause, if it is too much digitalis, it can cause heart blocks. And so 2 to 1 blocks will come on, but I don't expect you to remember all that. Okay. All right. Drugs that prolong QT interval. Okay, here. So look at this. And medications sometimes you give to control rhythm problems. Sorolol, pyridine, procainamide. These medications are you give to treat rhythm problems, but cause rhythm problems also. Like QT syndrome and TOSAs. Tricyclic antidepressants, some phenothiazines, erythromycin, usually in combination with antihistamines. So any of those can cause low QT syndrome. So if a patient comes with TOSA, this is the kind of history you want to get to see if they are on those medications, or it could be low calcium, low magnesium in your TOSA as well. Okay, so here's a low QT syndrome. The cardiac disorders and wait a minute. Pericarditis. Pericarditis is the inflammation of the heart, pericardium, that can cause fluid to build up in the sac called pericardial fluid. And when they have pericarditis, usually they have ST elevations, not just a heart attack like, but it's all over the ECG. So if there's ECG, ST elevations in all the leads, it's not a heart attack usually. And usually have fever, they feel like flu, like feeling sick, and those symptoms. See, so if you have diffuse, meaning more than the typical geographic area of the heart, ST elevations, then you think about pericarditis. Especially, they usually have low-grade fever and things like that. Pericardial effusion. Now, when the fluid builds up in the sac, then here's a normal ECG before this patient had pericardial effusion. And this is after pericardial effusion. What has happened? Huh? Size the QRS is smaller. This is called voltage, decreased voltage. See how normal QRS, and here how small. Why is that? Because you see now there's fluid around the heart. Electrical forces get kind of muffled, meaning kind of some of the electrical forces disappear. So the EKG becomes narrow. Another thing which happens is this. You see, what do you see in this one? What do you see here? What is this? This is a QRS. What's this? QRS also. QRS, QRS. What's the difference between these two? One is more normal or one is smaller. What happens there? So here's the heart inside the sac, and that's now fluid. So when the heart beats, one is when it is in the normal position, but with that one heart get kind of swings to the other side because there's fluid now, so the sac is not firmly holding because actually peanut heart. So when it moves to the other side, then you get a smaller gun. So this is called electrical alterans because it's alternate between small and big. And when you see this one, you have to say, "Oh, doctor, this patient probably has pericardial effusion," and they'll be impressed. Okay, hopefully. So remember, electrical alterans is in pericardial effusion. So it's always due to that swinging motion of the heart changing the electrical inactivity. Myocarditis, you get little conduction block with viral infections. Myocarditis also can cause pericardial effusions. I'm going to skip that. Pulmonary disorders. COPD patients also have smaller waves, because you see the lungs are so big, it muffles electrical activity. Sometimes they have small voltage, plus they can get right axis deviation. Remember pulmonary hypertension we talked about. So P waves, look at the P wave. See the abnormal P waves? Big, tall P waves? That's because of the pulmonary disorder. And pulmonary embolus. This one, usually people miss this. I had several patients I diagnosed with it's called S1Q3 T3 effect of pulmonary embolus, blood clot in the lung. So if you look at the lead one, there's an S wave right here, deep S wave. Any wave going down after the R wave is called an S wave. So lead one has this deep S wave, and then you have the Q3 T3. So if you look at it, there's a Q wave. The very first wave going down is called a Q, and that's a long Q wave. T3 meaning T inversion. See how the T gets inverted? So S1, Q3, T meaning T3, and T3 because T3. If you see that, that's a TB. Especially if you come with symptoms of shortness of breath and heart rate, then you usually take a cardiac. Sudden death, heart attack, arrhythmias, any arrhythmia can be, but ventricular fibrillation. With a heart disease, this is what my wife had. She had open heart surgery in April. This year she had mitral valve problem. Okay, commercial codis. Have you heard of that one? Kind of interesting name. We had about 3-6 months back maybe, a 12-year-old boy died in not far from Sacramento Valley. What happened was, you know what baseball is? Baseball is, and baseball is like a cricket ball. It's harder, but I think a little bit bigger. And he was batting. The bat is different, So the other fellow, they call the pitcher, like the ball, and they threw fast. And the ball came, he missed it, he directly right here. And sudden impact causes heart stop. They could revive if he died. That's commercial codis. You see, that's not common. It's really not common, but it happens. Of course, people with drug abuse, they get really bad valve disease, especially they do IV drugs. I've seen many of those. Rukada syndrome. Hey, interesting thing. This is common among, again, Orientals, like Chinese, Filipinos, and young people. And they have sudden death. They'll drop dead because they have this interesting ECG finding in leads anteriorly, V1, V2, V3, which look like ST elevation. See this QRS and ST elevation. So when they come for checkup with some problem, sometimes they come and say, I failed and do an ECG. This is how you pick it up. And I had a patient in Guam who had Hypokalemic syndrome, and this condition is life-threatening. So they have to have that implantable defibrillator we talked about, where they put it under the skin, and whenever they had ventricular fibrillation, it will give the shock and save them. So Hypokalemic syndrome is something fairly newly discovered, but it is a well-known entity now. Okay, did I answer that question? And they have no coronary artery disease, but they have sudden death with ventricular fibrillation. But if they do angiogram, the angiograms are clean. You see? So if you look at, they have this right bundle branch block. If you remember, V1, V2 are right bundle. They have that arc, they have rabbit tail-like thing, and they have this little ST elevation. See that? But it's not a heart attack. It's just that's Hypokalemic syndrome. There's a ventricular tachycardia, polymorphism. Athlete's heart, we talked about that, like Dr. Nia Lizilvas. His heart rate's low, and look how slow this is. It's very slow. If it create 100, 150, 100, 25, 60, 50, 40, it's about 38. And he's fine because their heart is well conditioned. But if I have it, I'll be on the floor by now. So, I don't think we have time to go through all this stuff. So, you want me to go straight so you can leave early? Or take a break? What do you like? We have only maybe one more. Go ahead. What do you say? Tired? Stop? Give up? I know it's tired, long day, but unfortunately I have only today available to do this for you. Any questions so far? You don't have Hypokalemic syndrome, do you? Yeah, so that's pretty much the last step, I think. Oh, there you go. Now you can sit back and say, I know how to read the ECGs. That's how I do it in the hospital. My legs up, man. Well, there you go. Michelangelo. So, ECG lead placement. Remember the frontal plane are the limb leads 1, 2, 3, AVR, AVR, AVF, and then we have the precordial leads, V1 on this one, V2, V3, V4. We can do V7 and 8 in the back. P wave is what? Atrial contraction. Left atrial contraction is what part? Second part. Right. Those who have COPD or pulmonary hypertension, which part will become taller? What? First part. So what's this? Oh, recording, the answers are there. Oh, that's too bad. But to review, normal sinus rhythm, rate is between 60 to 100. There's a P wave. Answer the question. Are there P waves? Normal P waves. Is the QR is narrow or wide? And is the rate regular or irregular? The P waves are in front of every QRS. Okay, next one. Heart rate is fast. But there are P waves in every front. Sinus tachycardia. Heart rate is slow, but P waves, QR is the same, slow, sinus tachycardia. Sinus arrest, because there's no P wave at all, there's a block. Sinus exit. Okay. What's this? Okay, start from the beginning. Are there P waves? No. Or you don't see. QR is narrow or wide? Narrow. Therefore, it is coming from where? Above the ventricle somewhere. Is the rate slow, normal, or fast? Fast. So what is it? Huh? Supraventricular tachycardia. Or if you say atrial tachycardia, it's also okay. But it is tachycardia, but it is not ventricular tachycardia, supraventricular because it's narrow. What's this? What kind of P waves do you see? Well, first of all, QR is regular or irregular? Regular. And there are multiple P waves. So there are, every third wave is a QRS complex. P waves are like sawtooth pattern. So it is atrial flutter. Yes, it's regular. Atrial flutter is always regular. And what's this? Atrial wide. No clear P waves. It's all undulating baseline, but QRS narrow, and it is irregular. Irregular. So it has, see, it is not regular. See, these two are shorter, this is wide, so it is irregular. And what's this? First of all, are there P waves? QRS is narrow and wide? Narrow. Regular or irregular? Irregular. So if it is irregular, then it must be narrow, it must be atrial fibrillation or atrial fibrillation. Can you see P waves clearly? No, but can you see P waves clearly here? Now, are there P waves all the same? So there are different P waves. So different P waves, narrow, complex, irregular is multi-atrial tachycardia like COPD. So multifocal but they still see P wave because it's coming from atrium. Okay? Ask if that's a PAT. Ventricular ones. So here, one PVC. So it's just single PVC. It's because it's wide, it's odd looking, and QRS and T waves are opposite. This is why is this accelerated ventricular? Because you have a good rate, decent rate, and it is generally a benign, meaning safe, and the patient will be okay. But it is coming from the ventricle because it's wide. What it is? Ventricular? Because wide complexes going fast, more than 3, ventricular tachycardia. This is dorsal because it's spinning around. Big, all PVCs, small, narrow, short PVCs going back to top. And what is this? If you get ventricular fibrillation, what happens? If you get ventricular fibrillation, what happens? Huh? Yeah, no P waves, no worry about that because it's coming from ventricle, but what happens to the patient? Die. What do you have to do? CPR. Right. Okay, blocks. PR interval is long, therefore it is a first degree block. That's the only thing you find in first degree block. Morbid type 1, you get a block. Type 1 is you have PR lengthening each time, going longer and drops. There's no QRS after this period. See how the PR interval is longer here compared to here, then a little bit longer here, then it drops a bit. This is generally safe. Novice type 2, regular QRS complex, drop P. Regular QRS complex, drop. No QRS after this P wave and after this P wave. Third degree block is atrial beats and ventricular beats totally not coordinated. They do their own thing. Like I said, husband and wife not talking to each other. My wife gets up and she tells me to go and sleep in the doghouse. Okay, so what's this? Let's see. You. This lady, this young lady right there. What's this? Okay, what do you see? It's okay, don't feel shy. I'll help you. Okay, you look at the QRS. What's this? This is what? Peak T wave. T wave. Remember? QRST. Peak T wave. What happened to the T wave? Wow, tall. Look at it. It's almost as tall as the QRS. Normally it's not that tall. So when you have peak T waves, what are the two possibilities? Perfect. I am so happy. Okay. So this is T inversion, which can be due to second phase of ECG changing and P-ST elevation. What do you have here now? What's this? Q wave. What happens? Why do Q waves form in heart attack? Because that part of the heart muscle is dead. Therefore, electrical forces are going opposite direction. All right. These are just rhythm testing. We don't need to do that. Okay. All right. Let's go find this. All right, ladies and gentlemen. Thank you so much for your patience and tolerating with me. And any questions before you go? No? Okay, everybody, we should give Dr. Leonard a big clap. Hold the applause for me later, okay? Now, there are two reasons why we have to applaud Dr. Leonard. One is that he explained a lot of stuff using very simple words and in a way that we can kind of remember it with a little bit of humor so that it's not like very serious. But what he said was really serious stuff. And it takes a long time, that means experience, to be able to teach or to be able to say something without using too much of words. That shows experience, that shows knowledge. Okay? Now the other thing we have to give him a clap for is that he's sick. He's taking a lot of medicines at the moment. His legs are swollen. I think he got acute filaria or something. And despite that, he's also lack of sleep. And the tea that he's been told to drink doesn't suit his taste very much. So anyway, he has made a great effort. I want to say just a little bit more about what he said. Can you believe that all what he told us today is from the shape of one line? Just one line. And depending on the shape of that line, look at the number of things that you can say about your health, about your anatomy, about your physiology, all from the shape of one line. Think about it. Amazing. I think the EKG was first used about 1910 or something like that. I don't remember. But
I think it was
very primitive. They put their feet in this solution in the basin, and that's how they used the electrodes at the time.
Mm-hmm. I think it was kind of first looked into by a Dutch fellow, I think.
Yeah.
A fellow called Eindhoven.
That's why they call it Eindhoven triangle.
Yeah, all right. And the three leads you call the Eindhoven triangle. Okay, and that's what we learnt in medical school. So, from those very basic observations, with the shape of that line and the changes, we are yet discovering new things. Now, see, he talked about Brugada's syndrome. I have never even heard of it. Okay, so I mean, there are things yet to be discovered, but the more important thing is we have to learn about what has already been discovered. Okay. So the very simple things like the rhythm, the blocks, are the most like basic things that all of us need to know as healthcare people, not as cardiologists, not as specialists, but just to be able to look at this one line and say, hey, this doesn't look quite right. And then for your own curiosity, you can research it with the help of somebody who knows better. Okay, so make full use of the material that you will get about this lecture later on. And as he said, this book is very, very helpful. Okay? All right. Luckily for you folks, he's not going to hold an examination today, but I might hold one for you next week. Okay, thank you very much for listening.
If you have any questions, I can be available for a little bit more time before we head back home.
If you have any questions, go and talk to Dr. Ranasinghe first.
So well, the heart doesn't have to work hard.
දැන් මේක ඩොක්ටර් ගේ මැෂින් එකේ තියෙන පෙන් ඩ්‍රයිව් දාන්න
So essentially, it was functioning at a low level, providing